participants, and hopefully that after this evening that you become a member of our McSwain family. We are here every third Thursday for Trauma Talks. If it's 8 o'clock Central Time and it's the third Thursday of the month, we're here. And we'd invite you to participate in as many of these as possible. As Mary alluded to, the McSwain Trauma Education Project is a charitable organization, and we're able to provide these conferences for individuals free of charge because of generous donations. So if you're able to, consider a donation to the McSwain Trauma Education Project or the McSwain Charitable Trust in there. It's wonderful to have everybody here. And on behalf of all the board members, thank you for your participation here. And with that, I'm going to turn it over to Dr. Ron Gross for introduction of Dr. Wayne. Dr. Gross.
Thanks, Steve. Much appreciated. Everybody, and thank you for joining the MTEP, the Triple T Trauma Conference. I want you to think about something here. I'm going to read you a little quote. If you make waves, you will hit rocks. If you never make waves, you will never change the shape of the world. Now, think about that. And the reason why I'm telling you that is because that is the favorite quote from tonight's McSwain Third Thursday Trauma Talk, Dr. Marvin Wayne. Dr. Wayne attended medical school at the University of Michigan and completed his surgical residency at the University of Colorado. He's a Vietnam veteran, as is the gentleman who was just speaking for us. He served both in Nam and at Fort Carson Army Medical Center, where he was awarded a Bronze Star for removing a live grenade from one of our soldiers. Dr. Wayne completed his surgical fellowship at Virginia Mason Medical Center in Seattle, and later transitioned from surgery. Oh, am I about to say this to the dark side? No. From surgery to emergency medicine and emergency medical services in 1974. He served as the medical program director of EMS for 50 years, and he is the associate clinical professor at the University of Washington. Marv has received the ACEP Award for Outstanding Contribution to EMS and the Lifetime Achievement Award from Washington ACEP. He has authored or co-authored well over 100 journal articles and chapters with special interests in cardiac arrest, post-cardiac arrest care, and airway management. Dr. Wayne is active in research and development in airway management and was a pioneer in the development of the AED, which was first used outside of a hospital in 1974. Think about that. Think about how many lives that machine and this doctor has helped to save. For well over 40 years, he partnered with Dr. Norm McSwain in areas of education and certification of paramedic training programs. He has provided many lectures in state, national, international, and local programs. And it is with great pleasure that I present to you Dr. Dr. Marvin Wayne. Marv, take it away.
Okay, that seemed like an appropriate comment at the end. First of all, it's way too much. You know, here's Marv would have probably been good enough. So let's do a share screen. Can we do that? And let's see if we can get this up. There we go. Now let's see if we can get this to full screen. And I am going to, can you all see that?
You're good, sir.
Okay, that's Dr. McSwain and I in actually 2015, where NEMSP was in Nolans, pronounced correctly. And Norm and I had dinner at Pascal Manali's with Mary in Patliljah. And when we left, we took this picture. And unfortunately, we looked at each other and said, we're both getting to that age. Who knows when again? And of course, there was not a when again. So I dedicate a lot of my life to the great achievements that Norm made, but also to the motivation that he gave. So from there, let's go to the challenges of airway burns, toxic inhalation. We are going to move relatively quickly. I am going to move through some of the videos very quickly, through others not so quickly, and tell some stories. And then we'll talk about what happens with the products of combustion. Okay, all of these are real. Only the dates, times, etc., have been changed to protect the innocent airway, and me from the lawyers. Here in Florida, every other ad on TV is for a lawyer. So I'm leaving town tomorrow before I get in trouble. In any case, so let's talk about some airway. Every one of these videos that you see was performed in the pre-hospital by pre-hospital providers, and not by physicians. So in Bellingham, Washington, early one New Year's Day, I got a pager went off and said multi-ambulance response to a house fire with entrapment, which always does not make you feel really good. I came on the scene. You can see the ladder truck is down and putting water. One of the fire captains broke through the back part of the house and evacuated 2 children and mom. Dad broke out the front door with a friend. He was not significantly burned except on his hands, where he tried to get back into the house. Bellingham, Washington, for all of you who don't know, is 2/3 of the way between Seattle and Vancouver, Canada. We aren't sure on good days whether we sing "O Canada" or "Star Spangled Banner." We used to be big hockey fans of the Vancouver Canucks. Now we're the Seattle Kraken. And so what can I say? In any case, that's where we are. We're the further northwest county in the continental US, and we are your northern protection. More importantly, we work in a state where the progress of EMS is paramount. We are a state that pushes the envelope. I work with great folks at the University of Washington, and we always have our internal challenges that we're better than, you're better than, but we're all trying to be better than for the benefit of the patient. All right, this initial pass went out, 4 engines, 1 battalion, 2 medics, and an EMS supervisor. Okay, on arrival, the EMS staff was added to the call because of there were 4 bad sick patients. Medic 2 came onto the scene and rapidly assessed. So now everything you're going to see next was done in a medic unit, not in the hospital. Because the flames were around us, we tried to do it quickly, and then we tried to evacuate the scene. I was on scene, but mostly what I did was watch. Because when you break the trend of how people are being cared for and what they do every day to work together, you only get in the way. And as much as I like to work with our EMS providers, you know, there's a time when I get the IV bag to hold. So there were 4 patients. And let me see if there, yeah, there were 4 patients, 2 children, a mom and dad. Dad had the least injury. So on scene, the first medic unit, medic 2, took the 35-year-old male and the 13-year-old female. And dad, as you'll see, had relatively minor injuries, 60% total body surface area, but it was mostly first, superficial, second. There was no significant, any material around the mouth. His airway was good. And we have, of course, Life Act 15 that gives us CO level, and the CO level was 0. The patient was awake, talking, coherent. An IV was started. He was given some Dilaudid, and he was covered with a clean sheet and put to the side, which was appropriate. The 13-year-old female had a 25 to 35% total body surface area. She was obtunded. She had a carbon monoxide level on the life pack, which is all relative, of greater than 30. And as you will see, she had significant airway compromise. This is her airway. And what you're seeing, of course, is soot. You're seeing the regurgitant of the pulmonary tissue that has been acutely damaged. This is the beginning of ARDS. You begin to see swelling of the glottic opening. You see deposition of soot-like material, and it continued. On this patient, we elected not to paralyze her since she was tolerating, and it's pretty impressive, that regurgitant. She was tolerating our attempt, and we were able to get her intubated relatively quickly, as you'll see. Okay, that's the 13-year-old. The second medic unit arrives and also got the other 2 patients. 10-year-old female, total body surface area of about 30%, legs, arms, face, but again, a significant airway involvement. This one, I want you to especially look. Now, if you look at the time sequencing, those first 2 patients were cared for quickly then there was a delay. Of course, this patient was being attended, but the amount of attending was, of course, variable because, you know, you just got so much going on. You have fire, you have all these things going on. So this is about, I would guess, 15 to 20, 25 minutes from the actual moment that she was overcome with the smoke and the materials and the heat, maybe even a little longer. I especially mention that because she obviously has a large CO burden, but more important, look at her airway. So open the mouth. First, you see a little bit of soot materials. You see regurgitation. I want you to look at the glottic opening. Look at the swelling of the areorypnoid folds. Look at the amazing swelling. Now, here's the problem. I need a big endotracheal tube we can put in. Now, if you look at an endotracheal tube, there's a bevel on it. And that bevel is like a cut to the right. It's a taper. So that when you crank the tube to the right, you will eventually act like almost like a drill to work its way in. So I'm standing over the medic's shoulder, looking on the screen, going, crank to the right, continue to gently push. Crank to the right, continue to gently push. As you can see, the sweat beating on him, and then we got in. Because if the tube was too small, we wouldn't be able to suction. And as you can see, there were copious amounts of regurgitant coming out of the airway. So that's a 6 tube that we're able to get in. This was a small 10-year-old, and I think the initial age was wrong. I think the child was closer to between 6 and 8. In any case, we got it in. A couple things to remember and learn from this. One, when the airway is swollen, the longer you wait, the worse it's getting. So if you think that was difficult, in 10 more minutes, you might not have been able to get it in. And now you're looking at a surgical airway, which is the least thing these people need, especially if there's burn involving the neck and cricopharyngeal area. Okay, so tube got in. The bevel helps you turn to the right. You ought to turn to the right anyway when you get the tube in, when you debate. Because if you go straight, you're hitting up against the back of the tracheal rings, which are right up against the mediastinum of the heart. So you're going to hit a barrier. So when you go through the cords, you should bevel, turn the tube to the right. It goes into the main stem, and then hopefully you don't go too far. Teeth 22 in adults, in the male, 23 in the female. Generally, we'll put you in the right place. Kids, you got to use a measuring system. We use the Hantevi app, and it just sort of tells us what to do in a child. All right, so now we got more patients. Now we got mom, 33-year-old female. She also is obtunded. Burn surface area is less, but CO is more. She was desperately trying to get the kids out, so she probably was exerting herself more and inhaling more of the toxic irritants and gases. She got an IO because she had burns on extremities, and then she did get RSI before the process of her intubation. The reason she got RSI, she was still moaning and such. She also got the louder. Okay. Probably we used rocuronium in her. We generally only use rock now. We don't use sucks. And our pretreatment, maybe or maybe not on her, I don't remember, would probably have been midazolam when she occurred. Nowadays, we're using an assortment of either midazolam or ketamine. All right, this is her intubation. Again, look at the material in the airway. When you get told in your textbook, you'll see carbonaceous sputum, you'll see swelling, et cetera, et cetera, et cetera. You see that in the textbook, but now you're seeing it in real life. So that's the difference, where I have the opportunity to show you what actually occurs in the real world as time goes on. So she gets intubated, and they all get transported. Couple of interesting things. We're going to come back later on as to maybe some of what we should have done and didn't do on these patients. This is several years ago. I had to save them for a fixed period of time for medical legal reasons, although it's pretty hard to identify somebody by their airway. In any case, they all were cared for in the ER, and then they all went to the burn center in Seattle. There's a couple of things in retrospect when we talk about products of combustion, which maybe should have been addressed a little more than they were in these patients. They were cared for, don't get me wrong. They were cared for, and they were given good care. And the ventilation in the ER was done with a moderate amount of PEEP because of the fact that they all had ARDS. But in retrospect, we'll talk about some of the other products that maybe we should have addressed, we didn't. Again, another house fire. Let's see if I can get that one to run. This is just, again, a couple of points I make on these patients. So again, edema, moderate. Soot, no. Looks like that airway is a little bit traumatized. I have no reason why. And the patient got intubated. Hopefully they crank to the right. See if they do. Yep, they crank to the right. Okay, another one. So let's, yep, that's the same one for now. Oh, this is one. I'm sorry. There, this is the classic. This gentleman had a pint of whiskey next to his bed. He had his cigarettes next to the bed, and he was in bed. Now, that's an exceptional combination to have what you're going to see next when you're in bed and see these wonderful things. Okay, so you can look at a little bit of his face. Again, not pretty de-identified. These numbers on the bottom, ignore it. They mean nothing. They're scrambled purposefully. But again, lots of soot. Look at the carbonaceous material in his airway. Again, your textbook said you'll see carbonaceous sputum. Well, yeah, but how many of you have actually seen it? How many have you already seen just tonight? And again, he was successfully intubated. He went off to the burn center, and I'm sure went home for another pack of cigarettes. All right, one more. Let's see if this one runs. Oh, this was another gentleman smoking in bed. I don't know why in my county, everybody quit smoking, except the people that smoke in bed. I want to make a point on this one. Look at the external lips, oral entree, and tongue before we even get to the glottic opening. Just want you to value, again, swelling along the tonsillar pillars, and then the edema of the oral glottic opening. So important points to see, to think about, and to think about addressing early on. Okay, let me move on. I think this is the last one. Oh, this was an 18-year-old. Again, house fire. I think he had his chemistry set working. He was making drugs. It blew up and started a fire in the house. And you can see again the edema, and again initial difficulty getting through the subglottic area, and he had to deal with. All right, so what have we said? We said that airways get burned. They most commonly get burned in closed spaces. The burn is, so I have a question, and you all can put it in the chat or however you want to put. If I take a blowtorch and I put it in your mouth, and with it on, obviously, and I measure the temperature in your lungs, what's going to be the temperature in your lungs? And the answer is normal, physiologic, because there's no vehicle to transfer the heat from your mouth to the lung. Now, you may burn up your mouth, but you won't burn up your lung because there isn't a vehicle, which is usually something of moisture or gaseous particulates that get to the lung. On the other hand, if you take high temperature steam and you inject it into somebody's oral cavity and nasal cavity, that steam will take the water vapor, water molecule into the lung. Same thing's true of burnt material, products of combustion. They will again cause the damage. So it's hot gases, particulate matters, and toxic inhalation that result in the burned airway. And what's the immediate response? Edema, sloughing of the lung content, reflux. You saw that in several of those patients, and it didn't take very long for it to occur. It occurred very quickly. So those are patients who you want to take control of the airway earlier rather than later. Okay, sclerotic edema, reflux, obviously the beginning of ARDS, which by the way was named, as we were talking about Vietnam, that we call that Da Nang lung, because only the people in Da Nang got ARDS. We in the South never did. Seriously, that's not true. But all right, so now beyond the airway and external burn, now what? Now what's going on? Well, that's a beautiful view from the air, but we got a different kind of air and airway that we need to look at. How do we manage the toxic inhalation injury? And this is the two-pronged approach I'm taking tonight. Everything I'm telling you about this global issue is true of adult and kids. The difference is in adult and kids is you have a much smaller margin of error in children because the circumferential area and the edema area get very small very quickly. So it's important, as I showed you in that one kid, where we worked hard and struggled a little bit, maybe forced in reality, to get a good sized tube into that airway. Somebody said to me, well, you could have just put a bougie down and slid it down over the bougie. Yeah, maybe, but that takes time. And then now what? What am I going to do different? Am I going to be able to do it any more efficacious? And I don't know the answer, but we chose to do it without a bougie. All right. Well, carbon monoxide was first described by our good friend Claude Bernard in 1857, kind of the year after I was born. Everybody thinks, but I'm not really that old. I'm pretty old. In any case, a lot more is known about CO and CO poisoning long since he described it in the French literature. He was obviously a French gentleman. It's gas, it's odorless, it's colorless, it's tasteless. It has a vapor density of 0.97, so it will sink. Will float on top of air. It's extremely stable, but on the same token, extremely flammable. And where do we get it? Well, there are some endogenous. Believe it or not, our body makes carbon monoxide. And we'll show you what that is in a second. And when everybody think about what's the answer, this is the so-called $500 question. And no, I'm not giving you really $500. Counties don't pay that much. The reality is, I'll tell you in a sec, exogenous, which everybody is coming familiar with, and then of course another exogenous substrate, if inhaled, is through methylene chloride. So let's look at them. Endogenous. When our hemoglobin molecule, the heme structural component of the hemoglobin molecule, is catabolized and broken down, it is the only reaction in the body that produces carbon monoxide. It is small, usually easily handled by cytochrome oxygenase, and it is only a problem rarely. We do see elevated levels in hemolytic anemia and even in sepsis, where there can be a catabolic state and a secondary hemolytic lysis occurring. So, but if it's the old, you're sitting at the bar and you're looking at the young lady next to you or the young gentleman next to you, and you go, hey, you want to know something unusual? Where can we find carbon monoxide? Well, and then you tell them in the body. In any case, after they punch you and don't buy you a drink, you're back to the beginning. But this is the only source within the body in normal fashion. Normal source of carbon monoxide, of course, is exogenous. House fire, electrical generators. So the classic, and we'll talk about this in a minute. The classic story is that we have a very large seafood processing facility, Bellingham Cold Storage. Fish comes down, crab comes down from Alaska and other waters, and it gets processed. Normally, it's warm enough that the doors are all open. They're running around in these forklifts. They're all driven by a gas-generated motor. Usually, it's produced as a byproduct of those is carbon monoxide. But usually, there's circulation in the air. It's not a problem. Well, we had a really, really cold day, and they put the doors down, which are almost never down, and nobody thought about what the forklifts were going to produce. And we had 20 people overcome with carbon monoxide. And we also had a similar thing when a furnace was, again, large fish processing in the area. A brand new furnace was put in and improperly vented. We'll talk about some of that more in a minute. And some of the problems that occurred. But normally it's from the house fire with entrapment. If you're open, like the dad, he broke out. He got out of that. And he wasn't badly burned. He wasn't badly affected by the products of combustion. Gas-powered electrical generators, automotive exhaust. Now that's becoming different. So just recently, our folks responded to an attempt to kill oneself, and they got there and the garage door was closed. They actually had to break the lock because the wife called, and here the husband is sitting in there with exhaust venting in, and it was not an electric car, so let's not go there. Venting But the catalytic converters on some of the very new cars are so good that they are able to essentially remove all of the significant carbon monoxide, which is good for our environment. Other things are, again, propane-powered vehicle like these, the forklifts were, heaters, camp stoves, boat exhaust. Now, here's another spot. So everybody has these cool motorboats, and especially the inboard engines, and people like to sit on the transom. Well, what happens is the exhaust comes out and it strikes the water depending on the direction of water flow. And a lot of that gaseous product will come up and affect people on the transom. So people have actually seen people just literally fall off. And it wasn't because they've been intoxicated by alcohol, but they've been intoxicated by carbon monoxide. Again, something to think about. And of course, some carbon monoxide is produced by cigarettes. And vaping also, by the way. The other source, we mentioned methylene chloride. Methylene chloride is a paint and adhesive remover. It's not something you exactly want to hang around, but people use it. I mean, it's used quite a bit. And after you inhale the fumes, that's why big warning on there. Do not use an enclosed space. And of course, there's always some individual of not good, how do I put it properly? Not good intellectual thinking at the moment. Somebody seeking to win the Darwin Award, who will do that in an enclosed space because they don't believe they can. And actually, the inhalation, it's converted to carbon monoxide in the liver. It's a secondary product of the substance. So, hey, pays your money, takes your chances. And if you're going to use this stuff, really vent the area. All right, what else do we know? What do we know about CO? It's the leading cause of poisoning death in industrialized countries. In fact, it may be responsible for half of all poisonings in the world. Now, think about that. You're going, well, what about here? What about there? Well, it just so many places that products of combustion occur, both normally in industry and abnormally in cooking and in after disasters. We'll talk about that in a second. And in fact, in the US alone, between 400 and 500 people die annually as a result of carbon monoxide poisoning. And the majority today, especially, are non-intentional because of the efficacy of the catalytic converters. And in fact, there are greater than 50,000 ED visits annually for CO poisoning. So let's move down that a little bit. As we said, most accidental deaths are due to house fires, automotive exhausts, indoor heating systems that are dysfunctionate, obviously stoves, gas-powered, charcoal grill. Well, that's another favorite I see people. So it's winter, but I really want to grill. So they put their little electric grill, their little charcoal grill inside the house, but they have the window open a little bit. Well, unfortunately, often they produce a heck of a lot more carbon monoxide than the ventilation provides. So again, realize that. In boat exhaust, which you would not think about, but do occur, and occurs especially in areas of the country where there are a lot of boats, the Great Lakes, the Southeast, and somewhat in California. All right. As we get older, not that I'm old, I'm just a senior citizen, they say. But as we get older, our abilities to create escape from a variety of environments get less capable. This gentleman has shown us, proved to us that not only can CO occur, but so can other substances of a different two-carbon structure. It's mostly male. It's almost intoxicated, as you saw those burns at the beginning. And these kind of things peak in the winter because obviously heating systems enclose windows because I don't want to be cold, and sometimes we don't do a very good job of venting. So just know about that. It also occurs, especially after disasters. This is some of the flooding in a variety. I'm not sure this is particularly from whether this is Katrina or some of the flooding here in Florida they had or anywhere. But the point is that people's ability to have power relies on generators. Generators, as a product of combustion, produce carbon monoxide. Generators are often all we have to rely on. And also different types of fuel-powered heaters. All of this in enclosed space is a guarantee of inhalation of significant percentages of carbon monoxide. So just think about it. Think about it. Other group that we really need to be sensitive to are those that are pregnant. This fetal hemoglobin has an enormous affinity for carbon monoxide. So in that fish processing plant that we had, I don't know, 15, 20, I can't remember how many. We had 3 women who were at various stages of their pregnancy. Every one of them went to the hyperbaric chamber. Even though the CO level of mom and carboxyhemoglobin level, so the field CO and then the ER carboxyhemoglobin levels were relatively low. They were like 12, 14, but the baby, if you think about it proportionally, the baby is getting significant greater percentages. And fetal hemoglobin just sucks up carbon monoxide and is devastating potentially to the baby. So again, mom may do great, but we have to protect the baby. So just if you are in an environment where you get in a fire enclosed environment with various heaters, propane, it's late at night here, propane powered vehicles and the like, just be very sensitive to the fact that the patient is pregnant, they need more aggressive therapy. Okay, it's very complex. It binds the hemoglobin with an affinity 250 times greater than that of oxygen. Now, if you think of that and then multiply it with greater affinity for the baby's hemoglobin, you really see how devastating it can be to the fetus. So just again, a reminder. It binds to other iron-containing proteins. Myoglobin causes a variety of myocardial toxicity, cytochrome oxidase and cytochrome, neuroglobin. It binds to the binding to myoglobin reduces oxygen available in the heart, so you get the toxicity of the myocyte in the myocardium. The other thing is, we all know the pulse ox is falsely elevated. So if you've got a normal pulse ox and an elevated CO level, you don't have a normal pulse ox. If you think about it, so you got a pulse ox of 98%, okay? And the carbon monoxide level is 30%. You don't have to be a great mathematician to know that that pulse ox is not registering very good oxygen. So falsely elevated. There's obviously, with that effect on the myoglobin, cytochrome oxidase, and a variety of other moieties, it causes significant secondary ischemia. It can cause dysrhythmias and, of course, dysfunction because of reduced myocardial oxygen supply in state of greater oxygen demand. All right. We know also it interrupts the myocardial oxidative phosphorylation. Boy, I would say that 20 times. It decreases the activity of myocardial cytochrome oxidase, which is really the terminal oxidase in electron transport chain. See if I think I had a picture of that. So this is you have to memorize this slide or you don't get credit at the end, just in case you think we're not tough. Now, seriously, this shows you where the myocardial effect is directly, and then the secondary effect at the various points in the Krebs cycle. So this is a very complex chemical reaction and something that is very important to address. So how do we treat it? I give you all the horror story, but what's it based on? The treatment is indicated when this SpO is greater than 10 or 12. My answer, when in doubt, the first thing you're going to do is, when unfortunately we sometimes do more than we need to, and that's put on oxygen. The other thing is that if you're seeing elevation on your life pack or whatever you're using, because most of the new modern equipment has the ability to measure CO, you need to be aggressive in managing that airway. And we'll talk about being aggressive and also being observant for seizures, dysrhythmia, ischemic events. Okay? Because the ultimate challenge is whether you go to hyperbaric oxygen. I believe this is the Virginia Mason chamber in Seattle. I may be wrong. Oh, no, this may be Baltimore. Maybe Baltimore chamber. Carbon monoxide is best removed by one simple thing, and that's oxygen and more oxygen and more oxygen. So at room air, putting high flow oxygen, and I don't know if they've measured with the new nasal high flow oxygen systems, but this is generic room air, just breathing, is 240 to 360 minutes. That's a long time. With 100% O2, generally by rebreathing mask, it's about 80 minutes. But in a hyperbaric chamber at a table 6, it's down to about 22 minutes. Does this make change on the neurologic outcome? Because logistically, getting somebody to a chamber may mean a significant transfer. And also, we're trying to fly at low altitude, for example, in a helicopter, because you don't want to make them more hypoxic than they already are by dropping the surrounding PO2. And that's the big question. And there have been paper after paper after paper on the pros and on the cons. I'll give you 3 indications. If their carboxyhemoglobin level is greater than 40, I dive them. If they're pregnant, I dive them. And if I'm not sure, I obviously, in all these cases, will consult with the experts at the chambers. These chambers, for the most part, many of them are multi-place. I just was in San Andres Island in the Caribbean, 3 months, 4 months, whatever ago. And believe it or not, they have a 3-place chamber in this very third world facility, except for the dive centers. They've got a hyperbaric trained physician who, she herself, dives between 7 and 8 a month, which blew my mind because they have so much scuba diving in what I would call not the most educated environment for people. You know, a lot of these people have no real skill in training. I've made over 350 dives, and every dive to me is Mr. Rogers beginner dive. And that's why I've done well through the years. Anyway, think about it. The other thing we can do that I think is to consider who these patients are. This is pretty straightforward. Multiple coma, focal neurologic seizure, pregnancy, again, history of loss of consciousness. The thing we can do is CPAP. We can put these people on CPAP right from the very beginning. If you carry it, we carry CPAP. One of our units now is experimenting with a ventilator with BiPAP. But we can do things that push more oxygen into the tissues. And it is excellent. It's also an excellent way, by the way, to pre-oxygenate before you intubate, is CPAP. And again, you might be able to do this and effectively obviate the patient having to go to a hyperbaric chamber, depending on your transport times. You may need a supraglottic airway or an endotracheal tube. This is stuff that, you know, they come in with the mask. We switch them from our unit onto the BiPAP machine or the ventilator in the ED, and we continue to push oxygen into the tissues. All important things to think about. Well, guess what? Just when you think it's safe to come out of the water or go into the water, and there are no sharks and no stingrays or anything else, like we saw 3 big stingrays yesterday, there is cyanide. And indeed, you know, don't smoke, highly toxic, but there's always got to be somebody in there that wants to steal a can. All right, so think about it. This could be in combination or alone. It's a very complex, again, agent. It's colorless. It's lighter than air. It's explosive. It's bad stuff. And the problem is, it is an inhalation. It's almost, if you've got an inhalation in an environment that's burning, flame burn, everything in our environment, our chairs, our rugs, our curtains, all the things we construct houses and things out of, break down into carbon monoxide eventually, water vapor, and cyanide. So all of these products that we have are synthetic. Often that when they burn, they produce cyanide. It blocks aerobic metabolism and energy production. Essentially, it makes our cells hypoxic. It's a byproduct of anaerobic metabolism, especially lactate. We'll see where that may be useful in saying, was this patient also exposed to cyanide? Because if they're exposed to a large volume of cyanide, there's not an issue. They're dead. They're dead. Because death occurs from central respiratory arrest. It's a metabolic death. Okay? Functional death, a little bit like carbon monoxide. It involves a lot of the metabolic cycles in our body. One of the clues to even moderate that might trigger you is high lactate. You know, even an elevated lactate can occur in any trauma or any of these environments, but rarely is a lactate greater than 10. High lactate in the presence of a low pH. So just think about it. Lactate's up, pH is down. None of us can measure cyanide, blood cyanide, so I'm going to put that in there. So here's the mechanism. And it's a bit, you know, complex. It's eliminated in the urine. there's transsulfuration, there's an enzyme called rhodase that is part of the process of breakdown. And the whole thing is to prevent that cyanide from going to the right and all of those complex toxic pathways. So what do? Well, we used to have this crazy Abbott kit where we essentially made people messed up their whole cytochrome system, and then we used sodium thiocyanate and a variety of things to take it away. Well, it turns out in Europe for like forever, they've been using what makes the most sense. What makes most sense is to add something called hydroxycobalamin, vitamin B12. And that then detoxifies by creating cyanocobalamin. So the cyanide molecule binds with the cobalamin molecule of hydroxycobalamin, and you free up a free hydrogen and essentially water. So that created the cyano kit, and then it's eliminated in the urine. So again, does not reduce oxygen carrying capacity of the blood, but it destroys the hemodynamics. It's a lot of problems. So what do? We give them hydroxycobalamin, vitamin B12. And of course, if you give them vitamin B12, it's got to cost a lot of money because it's in a kit. And it's ridiculous how much it costs. But it's expensive, and therefore people limit how much they have. It's a very stable compound, hydroxycobalamin. It does, because it is made with red crystals, there is a discoloration of the skin. You get red urine, you get the red man syndrome. We'll look at that in a second. So this is it. People get, again, this very transient, but very impressive reddening of the skin. And on day 1, and then by day 8, it's all gone. The important thing, and this is probably because of these red crystals, but it's very important that it's able to bind, creating cyanocobalamin, and remove it from the body. And this gives you an idea, the kinetics, how rapidly it works primarily, and then how rapidly it works secondarily during the elimination phase. Okay, so what can we say? We can say don't have a burned airway. We can say don't smoke in bed, don't drink and smoke in bed, don't do drugs and smoke in bed, and most of all, stay out of fires. But we also can say cyanide is very likely to be present in appreciable amounts in a fire victim's blood. And we often don't think about that. Often it's in co-exposure with the carbon monoxide and the cyanide. Carbon monoxide is likely a major toxicant in fires. And although carbon monoxide might be bad, a lot of these deaths may not be realized and be thought of as being from carbon monoxide, but they're from cyanide. Isn't that interesting? So remember, cyanide in and of itself, like CO, may result in lower than expected carboxyhemoglobin levels. Again, mixed metaphors of disaster, all up there for us to mess with. All right. Well, all we do in the pre-hospital, this is Andy McCoy's daughter, who's now quite a bit older than when this was taken. Andy's my colleague at the University of Washington. These are the UE scopes we use in our EMS system. And it isn't really child's play, but we like to think it is.
The first question says, you suggested 80 minutes of non-rebreather oxygen is reasonable for CO poisoning and 22 minutes by hyperbaric treatment. How would you approximate duration for CPAP compare?
The answer is a swag. Scientific wild ass guess. I don't know. I can guess that I think it's probably somewhere, if you think about, the long room air, then you think about oxygen, and CPAP is going to shorten that. I would probably think it's going to be maybe a quarter less, but I don't really know. I'm sure that data is in the literature, and somebody's smart enough to talk to Dr. Google and ask the question, but I really don't know. Probably should have looked it up. Now I look dumb.
Just a comment that I can make is it's nice to see that there's a lot of places now that are changing over to the SIO kit as opposed to the old sodium thiosulfate and amyl nitrate treatment. So we are seeing a lot more individuals and services and actually industrial agencies going with the same kits. So again, those of you that's in the service and everything, you should know what they have available in the areas that you're working in. And the
So-
other thing the other change that has come about that I think is very positive is the scope of practice has changed so that EMTs now have the ability to use a CPAP, which they've not had previously. That has had some benefits in here.
So let me add to your comment. Number one, see, I'm very lucky because I work in a state where they'll tell me I can't, but then they tell me I can. So we have one of our BLS units goes to the ski area, and I see some of my friends and neighbors on the Zoom tonight. And our unit that goes to ski area, the BLS unit, has nitrous oxide. So once they get below 1,500 feet, will work. So they give them some analgesia at the mountain, and then they also have CPAP, and of course everybody has Narcan because everybody needs Narcan, unfortunately. And we've just progressively given more special skills to our BLS providers. And I think there's a reality there because we have a lot more BLS providers than we do ALS providers. But that doesn't mean, so all of our BLS providers, for example, use supraglottic airways. And we've looked at our data. And they're required to retrain every quarter, even briefly, on just the management and the physical placement of the SGA that our system uses. And so I think these are all very good additions. I don't think they detract from the specialism of paramedicine, but I do think that they are very appropriate and very useful for BLS providers. So I think that's important. Of course, our ALS providers were needed, we think of nebulized epi for stridorous upper airway conditions. When anything atomized, I can't see the whole thing. So they're talking about atomization of inhalant. I don't know the answer, except that we know, for example, in croup that it's not terribly useful. But the question is something like albuterol. Would that be okay? Would epi be more absorbed, less absorbed? Would it help the edema? The answer is on a theoretical basis, all of these are yes. But on a practical basis, I don't know if anybody has studied them enough. I try to keep up with the knowledge and literature on this. But the main problem is any one center may or may not see enough of the acute phase. So, for example, we would send patients to the burn center at Harborview in Seattle, but these same, patients have been with us for a while, and then there's a transfer time. So the answer is, I don't know of any inhalation other than oxygen that's been proven to be effective.
Again, Dr. Wayne, I thank you for your presentation this evening. I found it very, very beneficial, and I think that a lot of individuals have. I've seen comments on here about the information in between there. So again, kudos for the presentation.
I appreciate everybody being here. I think there's a couple of bottom lines. One, suspect. If we don't suspect something, it'll never happen or it'll never be present till the guy that wakes you up and he says, do you remember that patient you saw last night? That's the classic story. We get an ER and you get an EMS, the one you went out to twice and didn't transport. But likewise, I've gotten very, very cautious about the minimalist amount of CO exposure. And I think we often don't check. Our firefighters are as good or better than we are in thinking right at the beginning. Most of our EMS is fire-based. So they have CO monitors. They can monitor the air. They have CO on the life packs that are able to monitor the patient. And of course, cyanide, it's a whole different thing. So bottom line, we had a terrorism discussion 2 weeks ago, and we looked at the ways that cyanide could be put into our systems, water and otherwise. We have in the entire county of 250,000 people, there are 8 cyanokits that we have physically available immediately, and probably another 4 that would be available within 15 or 20 minutes. The importance here is they all said, well, we call Seattle. Seattle isn't going to get there in 5 or 10 minutes, not unless they're shot out of a cannon. So unfortunately, the manufacturers have got themselves an unfortunately good deal. And I'm hopeful that some other manufacturer will create a cyano kit that's inexpensive, because there's nothing in it that it costs more than a few pennies. So if there are other questions, I'm happy.
Yep.
Any other thoughts? I'm happy to
There's
continue.
there's one more comment here for you. First of all, before that, I give a shout out to Mr. Slattery. He again verified that the videos were tremendous. But Dan has said, you mentioned CPAP for pre-oxygenation for intubation. Most EMS systems and protocols do not recommend it, or it's contraindicated to use CPAP for patients who are all altered or unconscious. What's your thoughts on that?
Yeah, define altered. As a patient spontaneously breathing. And that becomes sticky always. So I have, the nice thing about CPAP, you can put it on, you can take it off. The fear is you overinflate the lung, you overinflate the stomach, and you get regurgitation. Generally, if you elevate the head, which you should anyway, even elevate the patient, you can see how they're tolerating it. If they're completely obtunded, then they need a different kind of airway. All right. They probably need a supraglottic airway, or depending on how obtunded they are, intubation. So it's called looking at the patient. When all else fails, look at the patient. I made that mistake. I did a fellowship in England, and my first day on the ward was met with wanting to fall between the cracks of the building built in 1250 AD. Because the professor, I said all these tests I'd order on this lady with heart failure. He said, Dr. Wayne, in our country, we usually examine the patient before we do anything else. So look at the patient, talk, if they can talk, name, rank, and serial number. And if they're still struggling, though, you can help them. If it doesn't help them, you can always take it off. So that's my attitude towards CPAP.
Well, Dr. Wayne, again, on behalf of the McSwain Trauma Education Project and the McSwain Foundation, thank you for your presentation tonight and your support of Dr. McSwain in his legacy and continuing the trauma education throughout here. Again, and I want to thank everyone again for their attendance this evening.
May I add one last thing?
You sure can, sir.
I knew Norm, and I know right now he's looking very proud at you guys for what you've done. So I add my warm heart to you all for what you all have done to bring trauma where he wanted it to the streets. And also let anybody on this know, I put my email was on the last slide. It's simple. It's mwayne@Whatcom County, WHATCOM COUNTY, Whatcom County, one word, .us. And if I can help anybody with any of this material or others, please let me know. Because again, we need to share to help others and help ourselves at the same time. So thank you.